Welcome to Gosfield and Shay on Health Law.
Hello and welcome to Gosfield and Shay on Health Law with Alice Gosfield. Alice is a nationally recognized healthcare attorney who has spent her entire legal career advising physicians on Medicare, fraud and abuse, Stark law, and values-based payment. She is known for her strategic clarity, prolific writing, and deep influence on federal healthcare policy. I'm LeAnn Lyon, and today we are talking about prior authorizations, how they became such a dominant force in modern healthcare, and why physicians, regulators, and patients are all increasingly pushing back on the system. Hello, Alice. It's nice to see you.
Hi, Leanne. It's nice to be back. Thank you.
Alice, prior authorization has existed for decades. What changed recently that pushed it into such intense scrutiny from physicians, regulators, and patients?
The payers have used prior authorization increasingly over time, which is incredibly burdensome to physician practices, and there have been lots of problems and skepticism over the inputs into the review decisions that emerge from the prior authorization process. The industry has not been, industry meaning the managed care plans, has not been very good at responding to this. They issued in 1998 a consensus statement with all kinds of details in it about what they were going to reform, and they essentially did nothing, so that last year, 2025, they announced another statement far watered down from what the 1998 version had been. So the industry itself has more or less admitted that they have not reformed in the way they purported to back in 98. So the skepticism is not without basis.
Well, I know plans describe prior authorization as a utilization management tool. Beautiful words. How does that purpose compare with the way that the process actually functions in medical practice today?
So the one of the real challenges that emerges from the plan's use of prior authorizations is that they don't do it themselves. They contract with other organizations, pharmacy benefit managers who have been really raked over the coals just in the last couple of years, and radiology benefit managers that are apart from the plans and not necessarily subject to the regulations that the plans are subjected to. Some of the PBMs have profited off of the discounts that they've negotiated with the drug manufacturers, and the providers don't benefit from any of that. So they've come under enormous scrutiny for the essential corruption in the way in which their decision-making process goes. Many of us thought that the concept of what was included in a plan's formulary had to do with science, and when the pharmacy benefit managers negotiate with the drug manufacturers, the drug manufacturers sometimes pay incentives to the PBMs to be included. There's a very checkered history to the way this aspect of the system has unfolded.
Wow, fascinating. So, how has the health plan industry responded to all these years of criticism?
Well, they keep saying that they're going to reform. As I said, they published this big consensus statement that looked very rosy. It was very detailed. It described about 9 or 10 things that they were going to do with subcategories. And it wasn't everybody that signed on. It was a voluntary process. There were about 60 plans that signed up, but they didn't do it. And so they were faced with, because the states are now stepping up to regulate PBMs, some of the plans and other managers, the radiology benefit managers do imaging. Some of both of these companies have gone beyond pharmacy and radiology to other kinds of services. And so the expansion of where prior authorization applies has also been troublesome, certainly to the physicians who have to spend time coping with it.
So, the administrative burden associated with prior authorization is now heavily documented. But what does that burden actually require from physicians and practice staff on a day-to-day basis?
Let me give you some data that comes from a major article that I wrote on prior authorizations that you can find on my website at www.gosfield.com. Physicians report completing an average of 39 prior authorizations a week. They say it increases physician burnout. 75% of physicians report the number of denials has increased over the last 5 years. For a single physician, prior authorizations consume 13 hours of physician and staff time each week. 40% of physicians employ staff members just to work on prior authorizations, and 88%, that's an astonishing thing for physicians to agree on, report that prior authorizations lead to higher overall utilization, resulting in unnecessary waste by requiring ineffective prior treatment, additional office visits, urgent or emergency care, and hospitalizations. So it's a nightmare.
Wow, it doesn't really sound good for anyone. But predictive algorithms and artificial intelligence are increasingly being used as well in denial and review decisions. So, what makes those technologies particularly problematic in the prior authorization setting?
Well, the time that reviewers spend on evaluating a request for a prior authorization has decreased over time as the burden imposed on the reviewers has increased themselves. There have been many complaints about it. The real issue with artificial intelligence, predictive algorithms, are what are going to be the inputs? How much science is there going to be? How robust is it going to be? What is the capacity of these artificial intelligence mechanisms to actually analyze the clinical evidence in a way that's meaningful? It could actually be an improvement, but given the track record of the industry, I'm not hopeful.
Mm. Medicare Advantage has become a major focal point on the prior authorization debate. What does the appeals data reveal about how these denials are being made and reviewed?
Well, first, let's look at what the volume of Medicare Advantage prior authorizations is. Medicare Advantage insurers made nearly 50 million prior authorization determinations in 2023, reflecting steady year-over-year increases from 2021, when there were 37 million PAs, to 2022 with 46 million PAs. They fully or partially denied 6.4% of the requests. So here they are imposing a process where 93% of what it is they're looking at, they're approving. So what's the point of going through all of this? Of this 46 million reviews, only 11.7% of denials get appealed. So that means of the 46 million reviews in 2022, almost 3 million entailed denials, and only a little more than 344,000 were appealed. Most appeals, more than 90%, were partially or fully overturned. This really calls into question the validity of what the processes are that the insurers are engaged in. It also varies plan by plan. Some plans are worse than other plans.
Interesting. CMS has introduced new rules involving response times, transparency, electronic prior authorization systems, and these appeals processes. How will these reforms matter in practice?
So the rules have introduced a concept of something called application programming interfaces, APIs, provider APIs, payer APIs. An API is a set of commands, functions, protocols, or tools. This is a quote from the regs. Published by one software developer, A, that enables another software developer to create programs, applications, or apps that can interact with A's software without need to know the internal workings of A's software, while maintaining data security and patient privacy if properly implemented. So the new rules provide for more transparency of what services are actually subject to prior authorization. They have to be posted publicly on the plan's website. There are rules regarding when peer-to-peer, meaning physician-to-physician interactions must occur, as well as rules regarding the timeliness of decisions and the processes for appeals for urgent services versus routine services. Whether the plans actually comply with the rules is another issue. The states are increasingly becoming far bigger players in regulating PBMs and the plans with regard to these prior authorization mechanisms. The key for physicians and patients is to know their rights under the rules and complain when those rights get trampled.
Well, as we wrap up today's episode and taking a look at the broader trajectory of the healthcare system, do you think that prior authorization is moving towards meaningful structural reform, or are we still seeing just incremental adjustments to a fundamentally unchanged model?
Well, the CMS regulations are pretty detailed, and the state regulations are becoming increasingly more detailed. There's no question that prior authorization as a process is being reformed, but most of it is apparently not voluntary, taken up by the industry itself. United said just this week that it was going to reduce 30% of the prior authorizations that they require. Others may follow, but the yin and yang of regulation and response to it may improve things. I've been working in this industry for a really long time. I'm fairly skeptical about what's going to happen.
Understandable. Well, that is it for today's episode of Gosfield and Shay on health law. If you'd like to learn more about Alice Gosfield and her work advising physicians and healthcare organizations across the country, visit gosfield.com for more guidance and resources on healthcare regulation and compliance. Thanks for listening, and remember to subscribe, share, and leave a review. Thank you, Alice.
Thank you.
Thanks for watching. Be sure to hit that like and subscribe button and leave us a review in the comments.